So welcome everyone to the second workshop for track one, strengthening healthcare in developing countries. Our presenter today is Dr. Adam Damry. So he is a postdoctoral researcher at the Australian National University in the Research School of Chemistry. Prior to his graduate studies, he worked on the development of point-of-care genetic tests at Spartan Biosciences in Canada. Adam holds a PhD in protein design from the University of Ottawa under Dr. Roberto Chica. Following his PhD, he joined the ANU Our Health in Our Hands Grand Challenge to apply his background knowledge to the design of protein-based biosensors for disease monitoring and detection. So today, Dr. Damry will be speaking about approaches to managing pandemics from a detection standpoint and how awareness and education go hand in hand with monitoring and detection, sorry. So please, Adam, take it away.
Right. Thank you, Catherine, and thank you all of you for being here and being interested in this topic. Now, just kind of a bit of an FYI, I did record my talk last night, just in case of technical issues. So I'm just going to go ahead and play that recording, just make it simple. And then afterwards we can chat, we can discuss, ask questions, whatever. I'll be around for a little bit. And hope that you learned something from this. After all, that's the whole point of it. Welcome to the second talk in the Fighting Pandemics Hackathon, Stream 1, Strengthening Healthcare in Developing Communities. I'm Adam, and today I'll be talking about what is both a major problem and an incredible opportunity in our fight against disease. That of how to detect, track, and otherwise monitor these diseases in developing and remote communities. This is an incredibly important task due to how infectious diseases spread. We humans tend to get a little bit antsy when there are dangerous infectious diseases just running rampant throughout the population, and therefore, through medical history, we have taken steps to treat and mitigate these. In fact, we've already nearly eradicated many of the more dangerous diseases that are endemic to the human population. For example, smallpox, polio, measles, and yet, there are other dangerous diseases that continue to pop up with little prior representation in the population. That's because in many of these diseases that can go on to cause epidemics, the pathogens that cause them jump to the human population from other species. So from there, the index case or patient 0 can then go on to infect others. So we have our index case who is infected by a non-human reservoir, and from there, their disease gets passed on and spread throughout the population. And when we talk about local spread, we're talking about outbreaks, but eventually, if uncontrolled, exponential spread and travel leads to the development of an epidemic or pandemic event, where we have more and more infection that begins to spread beyond a community. And this is especially true in developing communities where the index case potential, that chance for a disease to jump into the human population, tends to be higher than in urbanized settings, as increased contact with animal hosts occurs in remote settings. And also, in these types of settings, whether it be far from urban cities or in developing countries, also tend to have fewer mitigation and healthcare systems that can mitigate outbreak and epidemic potentials. Now, it's unreasonable to expect that we can completely eradicate a disease that has a non-human reservoir. We can't simply go out and immunize every tick in the world against Lyme disease, or every mouse against the plague. So we can never really fully eliminate the risk of epidemics in society. But throughout this development of an epidemic, if we're able to identify and isolate carriers, either the index case or even the local carriers, we can halt the spread of the disease, and by doing so, stop it from ever reaching epidemic proportions, hence the need for a reliable means by which to perform these tests. Now, even in cases where the disease does progress to an epidemic, means of tracking spread and identifying carriers are incredibly important. With the advent of the COVID-19 pandemic, which extemporaneous current events. I'm sure you've all heard about flattening the curve as an objective. And the idea here is that understanding that we won't be able to stop the spread of the disease entirely, we can rather put in place barriers to the spread so that the peak number of cases does not overwhelm the capacity of our healthcare system. Now, in an outbreak, the reason why cases first go up and then back down is that a significant enough portion of the population becomes immunized, either through contracting the disease themselves or once other measures such as vaccines begin to come into play. And that hinders continued spread. And when we flatten the curve, as the proportion of immunized people rises more slowly, we extend the duration of the outbreak. However, in so doing, we also reduce the severity. And what's most important here is just stopping the number of cases from ever surpassing the capacity of our healthcare system to deal with it. Because once we can no longer treat new cases, then the problem just becomes worse and worse and worse. So this type of mitigation is especially important in developing communities and countries where healthcare capacity can be quite low. And even in developed countries such as Australia, there can be a plethora of isolated, remote communities such as those displayed here, with very difficult access to state-of-the-art medical equipment. And in developing countries, you have even more millions of people in similar situations, where the necessary medical infrastructure to handle an epidemic or a pandemic may not even be available at all. Kind of to put this in perspective with Australian numbers, though 90% of the population is concentrated in and around major cities, you still have that remaining 10%, almost 500,000 people living in what are considered to be very remote areas, and a further 2 million in remote areas, and these people are spread quite thinly, as you can see here on this map. And it is also these people who are most vulnerable to potentially preventable hospitalizations, usually because of disease complications, and to which there is a clear trend to remoteness. So here on this graph, you can see that as we tend from major cities towards very remote areas, across all of the categories being examined here, these potentially preventable hospitalizations increase proportionally to remoteness. And that's because these people tend to seek to avoid treatment because of availability until they really can't help it anymore. If you need to travel 8 hours to get to the nearest hospital, you're unlikely to do so unless you have a serious problem. And with many conditions, time can exacerbate the severity. So the longer they go without treatment, the worse it is once they actually need treatment. And this is especially true in an epidemic, where one carrier who goes undiagnosed can spread the disease to many others. And thus, to prevent this from occurring, it's very important to be able to make these diagnoses accurately, and also to be able to make these in these vulnerable communities where there may not be other means of healthcare, of mitigation. And the importance of detection, especially early detection, is very well illustrated if we compare two epidemic events here. The current SARS-CoV-2 pandemic and the SARS-CoV-1 pandemic of 2003, if you'd heard about the SARS epidemic back then. Some of you may be a bit too young for that. In fact, most of you. But as the names indicate, SARS-CoV and SARS-CoV-2, they are very, very closely related viruses. They're both from the coronavirus family. And yet, just by looking at these two graphs, which both depict new cases per day over time, we can clearly see a very, very different scale of infection. In the 2003 SARS epidemic, the number of cases peaked at maybe 140, a little bit more per day. SARS-CoV-2 is quite a different story. It's literally over 1,000 times more prevalent, with several hundreds of thousands of cases occurring every single day. So what exactly is the difference? Well, it really comes down to our ability to detect the disease, the virus, in its early stages, before it might have had a chance to spread. And really that is the key difference. And if we look at a comparison of the two viruses, so our two columns over here, we see that their transmissibility is very comparable. So this transmissibility value refers to, on average, the number of people that someone infected will go on to infect. So with a transmissibility of 2.5, you'd expect an average person who gets infected to spread the virus to 2.5 other people. And for SARS versus SARS-2, or versus COVID-19, if you prefer, their transmissibility is in fact very, very similar. SARS was not considerably less contagious. It is still a very, very contagious virus. But where the two differ most significantly, and what has really allowed SARS-CoV-2 to spread unchecked, is these factors over here. The interval between symptom onset and maximum infectivity, as well as the proportion of the population that display only mild symptoms. So here, with COVID-19, there's really very, very little time between when the disease begins to be symptomatic and when the disease can be transmitted. In fact, some carriers can become contagious before they even know that they're sick. They won't start coughing for a day or two after having been able to start spreading the virus. And there's also a very high portion of the population with COVID-19 that just never experience significant symptoms at all. So they may not realize that they're sick. They may just think it's a very simple cold, and yet they go on and infect someone else, and the disease can become a lot more severe in other cases. And because of these characteristics, SARS-CoV-2 has become much harder to track and isolate than SARS, which was a more severe disease, a very small portion of asymptomatic carriers, and a much longer interval between when the symptoms began to show up and infectivity, allowing people to go get treatment and diagnosis before they could begin to spread. And this therefore highlights the need for early-stage disease detection mechanisms that are capable of identifying carriers before they pass on the virus beyond simple symptomatic assessment, which is basically saying, I feel sick, therefore I should isolate myself, which works in some cases, but not in others, as COVID-19 has shown. And even beyond infectious diseases, detection and monitoring technologies have their place. For example, diabetics require constant updates on their blood sugar levels to manage their disease, the lack of which can cause very serious complications, hence the need for early detection and also monitoring mechanisms, as if you have diabetes and it goes undiagnosed, it can cause some pretty severe complications. And if we recall our graph from earlier about preventable hospitalizations, we can see that diabetes is significant enough to form its own category. Right over here. Again, because people in remote communities have less access to preventative healthcare, and therefore it is especially crucial for them to have access to easy and reliable monitoring devices. Now, another example that highlights this is also cancer screening, which has become more and more important as the population ages. Now you can get these types of home test kits to screen for cancer. And with cancer, much like with diabetes, early detection literally saves lives. Now this graph here highlights how cancer survival rates drop very, very dramatically as the disease develops from a typically operable stage 1, less severe disease, towards the more severe systemic stage 4 cancers, where the cancer is now beginning to spread through the victim's body. And thus, the earlier we're able to detect the cancers, the lower the chance that it will have progressed to further stages, and thus the higher the chance of survival. Thus, detection and monitoring technology has its place with all manner of diseases, both communicable and not. Of course, to say that we want to screen everyone for everything is all well and good, but we often, in disease diagnosis, run into the exact same problem of remoteness as in treatment. The most widespread technologies for disease testing very often require specialized personnel and infrastructure to carry out. Certain tests are run in hospitals, others are run in centralized lab facilities. And to show why that's a problem, well, here we've I've got a map of flying doctor service centres throughout rural Australia. And though this may seem like relatively decent coverage, there's quite a few of them spread around. It's very likely that many, in fact most of these, probably do not possess the necessary facilities for diagnostic testing. In fact, if we compare this with a map of hospitals with public birthing units, because that's what I could find, and that's a much more standard hospital amenity than a medical laboratory, we can see large swaths of the country, many of which host several remote communities, if we show our map of communities again, just kind of throughout Central and Western Australia, so very large regions of the country where these facilities are unlikely to be found anywhere nearby. And developing countries are likely even worse off. So, with a lack of infrastructure and a lack of specialized scientific personnel to carry out these tests, how do we go about doing our due diligence in detecting diseases in these regions? Well, the first potential method is to implement broad-scale screening. For example, many countries make use of thermal cameras in times of outbreak to scan for arrivals in airports or even throughout the population for fever or other visible signs of disease on these cameras. And this, in fact, was used to great success in containing the 2003 SARS epidemic. And the necessary technology is very cheap, very amenable, and easy to implement anywhere. So it's something that could easily be used in remote communities and in developing communities. Unfortunately, it's not 100% reliable. When it works well, it can work very well and very easily. However, that's not always the case, especially with diseases with a high asymptomatic carrier rate, or for those which become contagious before they become symptomatic. If you can spread the disease before you develop a fever, this won't be all that helpful. And both of them are characteristics of COVID-19, leading to a far greater spread of the disease. In fact, this technology was trialed and just was not effective in containing COVID-19. There are other technologies, however, that can prove useful, such as the application of sensing technology, of even individual sensing technology, to large-scale tests that test for the presence of a disease in entire communities rather than in individuals. So the principles remain the same. Usually you're running the same tests as you would run on a single person. The difference is merely with where we source the sample. If you're testing a person, you might take a saliva or a mucus sample and test that for the presence of the disease. Whereas for a full community, we could test perhaps wastewater, or for airborne diseases, air samples in crowded areas. And in theory, here, the viral load in our wastewater sample will be correlated to the number of infected individuals in the community, all contributing to this one pool of wastewater. And therefore, by testing several different geographical sources, we can then start to paint the picture of disease spread and prevalence, and regionally see what areas are harder hit than others. And these types of tests are also great for developing communities, as we're not running thousands upon thousands of tests, we're just running a few tests at a time, strongly reducing the infrastructure that's needed to analyze all of this material. And so you can run just a few tests in several different communities and start to paint the map of where the disease has spread, where it hasn't, and how we can stop it from spreading further. In fact, we can also tell, once the disease has established itself in a community, then we can move on to more stringent individualized testing, as this community-wide testing will give us an idea of if there's even any need to go to a more stringent person-by-person testing. But that's all well and good. Once we know that the disease is in a community, how do we test for it? Well, when you don't have access to personnel and infrastructure, again, the greatest hurdle to testing and monitoring in developing and remote communities, then the only real solution is to develop a test that doesn't require them. And that's exactly where medical science is going. Modern medicine is turning more and more towards what we call point-of-care testing, which is to say testing outside of a dedicated facility. And the point of care itself refers to the clinic or the doctor's office, the point where you are receiving care. And the philosophy behind point-of-care testing is to use simple, portable technology and easily interpreted results, such that the tests can be directly administered by an untrained nurse or doctor, or even someone at home. So someone who hasn't been trained specifically in administering and analyzing the tests. And though only the simplest of tests might actually make it into homes, which is really the end goal of developing point-of-care testing, anything that takes us beyond the hospital and the peripheral lab is still a step in the right direction, even if we're limited to testing in clinics, rather than being able to test either throughout the community by just untrained health workers, or even testing at home. These types of tests still present incredible advantages to the medical field, especially for developing and remote communities. And first and foremost is the lack of dedicated facilities that are required for the analysis. Typically all you need is a small apparatus or testing kit, which can easily be shipped in even to remote areas and used in the field. Beyond this, though, these types of tests also drastically reduce the amount of time needed to get a result, from several days to even weeks in the case where you need to ship samples from a remote area to a centralized facility, to mere hours or minutes when the test is administered and analyzed directly on site. And this is incredibly important with many infectious diseases, where prompt diagnosis is key to identifying carriers and preventing spread. And if we can push further and further towards home testing, then we can even limit exposure of medical personnel to patients, with the patients able to self-diagnose, therefore helping to keep our frontline essential workers safer and to further limit spread. So how do current point-of-care tests work? Well, if we're trying to detect an infectious disease, there are really two potential targets. There's the disease vector itself, so the virus or the bacterium, whatever it is that's causing the virus, we can target and detect that. Or we can detect the host's immune response to the pathogen, so the antibodies that are produced by the host, or an inflammatory response or something of the sort. And both of those streams, so either detecting the target or detecting the effect, have their own platforms and technologies. Now in the case of direct disease detection, where we're trying to detect the pathogen itself, we usually use techniques that we call nucleic acid testing, where we try to detect a DNA or RNA sequence that is specific to the pathogen of interest. So the way this works is we start by taking a sample from the patient that is likely to contain the pathogen if they are positive. So in the case of COVID, for example, which is a respiratory virus, we'd likely take a sample of mucus from the respiratory tract. So if the patient is sick, the virus will likely be represented in the sample. Then we extract the nucleic material from that sample, so the RNA and DNA that's present. Now, if they're sick, this extracted nucleic material will contain a small proportion of viral or bacterial DNA, and that we can target and amplify it with a few different technologies, including polymerase chain reactions. And what's important here is that we're specifically targeting and amplifying the nucleic acid material of interest. There's going to be a lot of DNA from the patient in a sample coming from the patient, of course, but that doesn't interest us. And we have ways of specifically targeting viral RNA from a virus of interest, or bacterial DNA from a bacteria of interest, and analyzing how much of that is present in the sample. And that gives us a very, very good idea of what the actual bacterial or viral load in the sample was, and therefore whether or not the patient is sick. And these are extremely precise tests because of this amplification factor. You can have just a few molecules of the target DNA in your solution, and because we amplify over and over again exponentially, this ends up creating a signal that we're able to detect. And so these tests are very, very sensitive, very, very specific and precise, and very effective at detecting whether or not there is directly a pathogen in the sample being tested. The second type of test that is often administered, my slide will change, is what we call a serological test, here referring to testing blood serum. And these tests are the ones that are used to detect the host's immune response to a disease, as one of the primary determinants of immune response is the production of antibodies that circulate in the blood against the target. And the way these tests work is we'll have a chip, so this is a porous chip like a filter paper or something, on which we add our analyte of interest, usually a blood sample. So our analyte is added at one end of the chip, and then it slowly starts to diffuse through the chip. And along the way, it'll come into contact with a labeled detection target. So in some cases, this can be an antibody. Sometimes it's a protein that we might be using to detect an antibody. But it's something that will attach to our target of interest, and it's labeled with a colored compound. So if we have our target of interest in the analyte starts to diffuse through, this colored receptor will attach onto it as it continues to just slowly travel down this chip. Then it'll reach two strips, one of which is a detection strip and one of which is a control strip. So our target of interest will attach to the detection strip if it is present, and therefore locking in place these colored compounds on that strip as well. If our target of interest is absent, however, then nothing will attach to this line. All the colored compound just keeps moving. And then we've got this control strip, which will just attach to the colored compound itself, regardless of whether the analyte is present, just to tell us whether or not the chip worked properly. If the solution never does make it to this line, then the test is considered inconclusive because you don't know if it actually made it to the positive line either. And so, in these types of tests, you'll always, or at least hopefully always, have some color appearing from aggregation of these colored groups on the control line. And then, if a positive test was determined, you'll also have the appearance of color on the test line. And so these are very, very simple tests, very cheap and very easy to administer. We simply have to take a sample, put it at one end of a chip, and then look at the appearance of color. And this is the same technology that is used in pregnancy tests, for example, where we're trying to detect the presence of a certain hormone in a urine sample. But we're doing the exact same thing, except that we're trying to detect an antibody in a blood sample. Now, just to show you a few examples of how these technologies are being used to combat COVID-19 currently, I'm just going to go over a couple case studies of a few startups or other companies, or not startups, but of a few technologies that some companies have already developed in order to do point-of-care testing for COVID. So the first one here is the Cube by Spartan Biosciences, which is a nucleic acid test. So here we're directly detecting COVID-19 genetic material. It uses cyclic amplification, kind of what I was talking about on the nucleic acid slide. You're looking at about $10 for a test and results in 30 minutes, which is amazing considering that the alternative is to ship a sample to a lab, wait 3 days for your test results, during which you're just there wondering if you have the disease or not. Abbott Laboratories is also developing a nucleic acid detection test. This one doesn't use cyclic amplification. It uses a different form called isothermal amplification. The specifics aren't important, however. There is still that amplification step that is present, that is very characteristic of nucleic acid detection. This one runs about $25 a test, but the results are obtained in under 15 minutes, and you can test for up to 12 different viruses at once, depending on what your actual chip is. And if we look across the pond at serological detection, this is a system by Cellex, which is a lateral-flow assay. It's of unknown cost. They haven't commercially released it yet, but the reagent cost is probably under $5 per test. And this will give results in about 20 minutes, where you take a sample, put it on this chip, and then just look at whether or not you have the appearance of that positive test line. Now, where are the areas for improvement for these tests? Well, nucleic acid testing and serological testing each have their own advantages and disadvantages. Nucleic acid testing is incredibly accurate and and very quick, very cheap, at least to administer the test. However, nucleic acid testing in other ways can be seen as being by far the more expensive of the two tests, because you do require that analyzer. As much as one test might be $10, you still need the instrument that does the amplification, which can range in the several hundreds to several thousands of dollars. And that isn't required for serological testing. In the case of serological testing, on the other hand, you don't have the same level of accuracy as with nucleic acid testing. These tests, especially new serological tests, can have a lot of accuracy issues, where you can have a lot of especially false negatives, where someone might be sick, but they just, the concentration of antibody in their blood sample might be a bit too low to detect, and therefore you just don't pick it up, and you would say that they're not sick when in fact they are, and that's a big problem, as you don't want someone to be told they aren't sick, they go out in public and they infect someone else. And serological testing also has a bit of a time delay between when someone gets sick and when their immune response becomes strong enough for it to be detected. There's also a bit of a time component that can be improved here. And in both cases, we want assays, or we want tests that are as simple as possible, so that anybody, any layperson, can administer the test themselves. And thus, for that reason, in order to still be able to get accurate and reliable results from a test, your average person on the street needs to be able to do it without any problems, without any training, and with very rudimentary instructions. And really, those are where the biggest areas for improvement are for these tests. They come with simplifying and cheapening sensing technologies. If every platform we have was as easy to use and as cheap as a pregnancy test or glucose monitor, then disease prevention and mitigation would be far easier than it is today. And in addition, beyond cheapening and making the technologies easy to use, we simply want it to be really simple. The fewer steps, the fewer components, and especially the less thought that needs to go into a test, the more useful it becomes, as simplicity is, again, important to get reliable and reproducible results from a non-expert user. And that always needs to be at the forefront of any test's design. And ultimately, the goal is again to be able to get these tests not even to the clinic, that's great already, but to get them to people's homes so that they may be able to safely diagnose themselves. And one note I'd like to leave you on is that with many of these tests, the most expensive parts are the analyzers that perform them. In nucleic acid testing, again, we're looking at a $10 test with a $1,000 analyzer. But most people, even in many developing countries, though not all, have ready access to moderately powerful computers in the form of your smartphone. And more researchers are trying to levy these tools and design accessories and tests that harness the computing power of a smartphone to provide even cheaper and more accessible testing platforms for lay users. We also need ways to take these test results and turn them into concrete deliverables to mitigate risks and outbreaks. And these generally take the form of policies, such as the shutdowns we have experienced and are still experiencing, mask regulations, social distancing, etc. And these policies are the result of data analysis. It is our tests that tell us how to enact and administer these policies, and thus we need good ways to aggregate and analyze data to look at trends. You don't want someone to test themselves at home and say, oh, I'm sick, I'm going to stay home. I'm not going to tell anybody. You want to be able to know where in your population and how much of your population is sick. And thus it's important to be able to track other demographic metrics as well when working on disease detection, such as, well, yeah, so tracking and understanding the data, the numbers. And you also want to be able to track other metrics, such as vaccination rates, for example, to understand if our other means of prevention and mitigation are proving effective, and especially to better understand the disease itself. For example, is reinfection possible? Is reinfection probable with a disease? Sometimes yes, sometimes no. And thus, testing in its various forms can give us a very good idea of what else needs to be done to contain and eventually halt an epidemic. And finally, The last note I'd like to leave you on is that another of the biggest factors in mitigating a pandemic really is proper education and awareness. We can test all we want, but if the public isn't willing to listen, isn't willing to diagnose themselves, and diagnostics and even policies just aren't going to work. In modern times, we're seeing greater and greater disillusionment towards government and policies, and people who are actively putting themselves and others in danger. Not because they want to put others in danger, not because they want to endanger themselves, not because they're stupid, but rather because they're uninformed on the matter and just simply don't understand the scientific basis behind decisions that are being made. And this disconnect is incredibly dangerous to our efforts to make society healthier and safer. This is not particularly new. We've seen it time and again with such movements as anti-vaxxing, and beyond that, in developing countries as well, where the understanding of modern medicine and epidemiology is very rudimentary. As in the Ebola epidemic of 2014, where doctors were being outright impeded and sometimes even attacked by an uninformed public. Thus, I hope that this presentation has helped you to understand the importance of proper testing and diagnosis in the mitigation of infectious disease, both in developed communities, but also and especially in remote and developing regions, and that you are all now overflowing with ideas to brainstorm as to how to approach this problem. Thank you, and I'd be happy to take any questions you might have. All right, and that is that for the talk. So again, if anybody has any comments, questions, be happy to answer, have a chat, do anything.
Oh, we've got a question from Nee. Do you know any company who is close to inventing a home testing kit for COVID-19?
Yeah, so that's a bit of a tricky question, because when it comes to being able to have a home testing kit, there is a lot of regulatory testing and a lot of regulatory processes that are required. So there are several companies, a lot of the bigger pharmaceutical companies in the world are at least investigating the problem. And several of them have put forth products that have a certain level of accuracy, but a lot of them are now in clinical testing stages. So they're not going to be able to sell to the public until they get approval from like the FDA in America, or whatever the equivalent regulatory agency in Australia is, and those can take quite a long time. As well with home testing, you're kind of currently restricted to the lateral flow assays that I was talking about, because nucleic acid tests, while more accurate, require these expensive analyzers. So for those ones, there's a lot of tests that are being touted for kind of the doctor's office or the clinic, but not so much home. On the side of lateral flow assays, the ones for COVID in particular haven't been extremely successful so far, because COVID is a disease that elicits a very weak immune response compared to a lot of others. The concentration of antibodies in blood for COVID tends to be very, very low compared to a lot of other pathogenic diseases, and that makes detection more difficult. But we are making progress. There are companies that are getting closer, and a lot of academic research being done on the topic as well.
I
Yes.
think we also have a question from another team. With me?
Yeah, I just had a question in regards to hospital management, and if we're looking into like doing something with changing the management of the hospital in regards to like say hospital framework, like doctors being pre-notified about the purpose of the visit of different patients, how would that go about? Like, would that be something that's possible?
So I will admit that I'm not terribly familiar with the framework of how a hospital functions, but I would expect that, especially once these tests start to become more widespread, that you would definitely be able to get tested even before going to the doctors and have the doctor be informed about the situation. It is extremely relevant information for them to know both how to handle a patient and also what to expect. As again, doctors and nurses are right at the front lines of epidemic treatment and prevention, and they're amongst the most vulnerable population, because they're in contact with so many patients that may or may not have this disease.
Yeah, okay. Thank you.
Were there any other questions?
Hi, Adam. I have a question about the test for the virus itself. Is there any barrier that prevents people from taking their own sample and maybe mail the sample to a testing clinic instead of going to a clinic? Like mail the sample to get analysis and get the results?
Yeah, so for sure, there's we just really don't have the logistical systems in place to do this at the moment. But there's really nothing stopping us from doing that. In the case of serological testing, it's a little bit more complicated because antibodies can be very unstable. It depends on the patient. There's a huge variability from person to person with how their antibodies behave, and there's no real rhyme or reason there. For nucleic acid testing, nucleic acids are very, very stable, and so you could just take a mucus sample, seal it up, send it to a clinic, and have it analyzed. We just don't have the logistic systems in place to do that yet, but it's very, very much a possibility if those systems get put in place.
Okay, cool. Thank you.
And yeah, for the other question in chat, for the case of COVID-19, it seems like urban areas are more susceptible. So that comes down to just how a disease spreads, right? Generally, in most cases, during an epidemic, there needs to be contact for the disease to spread, right? And the reason why urban areas tend to be more susceptible is twofold. First of all, the population density in urban areas tends to be a lot higher, and therefore you have a much greater contact with other people in the community around you. So if one person gets sick, it spreads much more easily to others than if you're more spread out kind of in a rural setting. And the second factor is that there tends to be a lot more travel in and out of urban areas as well. So a community that's very isolated, that doesn't have much person turnover, if there isn't anybody coming into a community, the risk that the disease enters the community is also extremely low. It's non-zero, because you'll always have a little bit of travel in and out of regions. But the more people you have coming in, the greater the chance that someone who is sick and doesn't know it brings the disease in with them. And in urban areas, there's a lot of travel. Cities are very much transportation hubs for regions. And thus, it's those two factors together that make diseases really root into cities a lot more easily than in isolated communities. The flip side of that is that if a disease does spread to an isolated community, then it can be a lot harder to contain and to manage, because you won't have those healthcare and mitigation systems in place like in cities.
I had another question in regards to the data collection systems for about the patients. How, who would we try to get in contact with to get the message across to, I guess, remote communities and someone they trust? Who would who would be able to get that message across? I'm just wondering.
Yeah, so it really depends on the community in question. But say if we're talking about just kind of like a remote community in Australia, then you'd likely be able to first get kind of any healthcare workers on your side first, and then from there kind of just pass on the word. It does become a lot trickier in developing communities where the people may be more more cautious and less understanding of outside assistance and outside help, as we definitely saw kind of in the Ebola epidemics, where the population just were very untrusting of the doctors that were coming to help them.
Mm.
And in this case, this is just kind of personal opinion, but I think you'd really want to figure out who in the community is trusted and respected by the locals, and try to approach them first, rather than just jump headlong into a community and try to get everybody to understand something. I think these communities tend to be, again, a little bit cautious of those outside the community. And so you'd want to be able to ideally have someone internally that you can approach and kind of brief on the situation, and from there kind of spread it through local lines.
Okay. Yeah. Thank you.
Are there any more questions from participants? Cool. So if there aren't any more questions, Adam, thank you so much for talking about the potential of point of care testing. I think especially in the time of the pandemic, the development of this type of technology is just so crucial to protect individuals and larger communities, especially in developing countries. So I also think it's just really exciting to see the future role that this type of technology plays in supporting greater access to healthcare. So thank you so much for leading this presentation. And this actually concludes the series of our workshops for this hackathon. Adam will be on Remo just to jump around and help your teams and answer any questions that you guys might have further. So with that, I'll direct everyone back to Remo, and we'll see you guys there. So thanks for joining and tuning in on this presentation, and yeah, we'll see you on Remo.
Thanks again for listening, and yeah, I'll be over on Remo in a moment as well.
Yeah, see you everyone.